The following podcast is part of a certified educational activity titled Candid Conversations and Clinical Consults in Community Context, Practical Guidance for Integrating TROP2-Targeting ADCs into Patient-Centric Breast Cancer Clinical Care. Access the entire activity and complete the post-test at peerview.com/JWM860. Downloadable slides and practice aids are also available.
Hello, welcome. Today we'll review candid conversations and clinical consults in the community context. We'll focus on integrating TROP2-directed antibody-drug conjugates with a patient-centric view related to breast cancer. So I'm Aditya Bardia. It's my pleasure to welcome you all. I'm Associate Professor in Medicine, Harvard Medical School, attending physician at Massachusetts General Hospital. Today we have an esteemed panel. It's my pleasure to introduce Erica.
Hi, I'm Dr. Erica Hamilton. I'm the director of the Breast and Gynecologic Research Program here at Sarah Cannon Research Institute at Tennessee Oncology. Happy to be here. Thanks so much for inviting me.
Absolutely. And Maria?
Hi everyone, my name is Maria Shellock. I'm a research nurse manager here at Mass General, overseeing the Cancer Center Protocol Office. Thank you so much.
Welcome. So without further ado, let's get started. We'll have 3 modules today. The first one is delving into details of targeted TROP2 in breast cancer. So we'll start with the first module about TROP2. So first, let's review the unmet needs and opportunities for improvement for patients with breast cancer. Why is there interest in TROP2? TROP2 is expressed across all breast cancer subtypes, including aggressive subtypes like triple negative or ERP or HER2 negative breast cancer. And the field is moving away from cytotoxic therapy and more towards precision medicine-based treatment. Targeted chemotherapy or antibody-drug conjugates have transformed the way we think about giving treatment to patients with breast cancer. Early data suggests that about a third of patients with metastatic breast cancer could benefit from TROP2-directed antibody-drug conjugates such as Sacituzumab Govitecan. So it's really important because it would offer access to patients who otherwise do not have a very good prognosis. So we'll review the data behind Sacituzumab Govitecan, and we'll also talk about management of toxicity related to this agent. For this program, we partnered with Metaviver and Living Beyond Breast Cancer to help integrate patient and advocate perspectives into this program. And that's the mission of Metaviver and Living Beyond Breast Cancer. It's to improve patient outcomes. The thought is that patients should be appropriately informed and educated about their treatment, including clinical trials that they're eligible. And by integrating patient and advocate perspective, we can further improve the care of an individual with breast cancer. And the belief is also that clinicians and patients should engage in shared decision making to ensure that the right patient receives the right treatment. And with that philosophy, today we have a patient who will share her story with metastatic triple-negative breast cancer. This is a patient that I have the privilege of taking care of along with Maria. And she'll review her metastatic triple-negative breast cancer journey, how she is doing well on the current treatment, and offer a patient perspective. So let's listen to her testimonial.
My name is Melissa. I am currently 39 years old. I was diagnosed with breast cancer September 21st of 2020. I was 38 years old at the time. At that time, I had surgery. I had a single mastectomy on my right side to remove the cancer. And shortly after, I started chemotherapy. That was the end of December of 2021 and through May of 2022. I received 2 different types of chemotherapy treatment via infusion. And then I thought I was on my way to recovery. I went for my appointment in August of 2022 to start radiation. And at that time, I found out that there was a tumor in my left lung and my cancer had spread. So at that point, radiation for my right side, where my cancer originally was put on hold. And I had 4 intense treatments of radiation for my left lung, where my cancer had spread to. So at that point, my radiation oncologist referred me to Dr. Bardia down at Mass General. I met with Dr. Bardia and Maria, his nurse, and the team down there, and we talked about, a clinical trial. Given the circumstances of my breast cancer and the fact that it had spread all through previous chemotherapy, a clinical trial was something that I considered in hopes that, because the standard chemotherapy didn't work for me, that this would work for me. So I started October 2nd of 2021 and have been undergoing this clinical trial since. It's a 21-day cycle. I have on day 1 infusion, day 8 I have infusion, and day 15 through 21 I take an oral chemo drug, 1 pill a day for 7 days, which is also part of the trial. Since October, my tumor has shrunk, 33% total. I've had great CAT scan results. I have a CAT scan every 8 weeks to kind of see where things are and make sure that treatment's working. When I met with Dr. Bardia in August of last year, when I found out my cancer had spread, he informed me that this is considered a chronic illness and something that I would have to live with probably for the rest of my life. That's hard to hear when you're not even 40. And to try and live a normal life and be a mom. But on the bright side and the positive, this clinical trial that I'm on is working, and it is allowing me to live my best life. And the side effects that I have are very minimal.
Okay, that was very inspiring, and it's great to see the patient do well. I'll also like to review another case. This is a patient I had seen a couple years ago, a patient with metastatic triple-negative breast cancer who initially had lumpectomy and radiation therapy, then received adjuvant ACT treatment. Unfortunately, 2 years later had disease recurrence. She presented with shortness of breath to the ED, had restaging scans, which revealed lesions in the lung and liver. As per recommendation, she had a biopsy which confirmed that this was breast adenocarcinoma and was the same as before, ER, PR, HER2 negative or triple negative. Now, for a patient with triple negative breast cancer, there are 2 biomarkers that are recommended. The first one is to evaluate for PD-L1 status because that could impact management. And the second is to look at germline BRCA status. So this was done for this patient. She did not have germline BRCA mutation. So she was started on first-line therapy with carboplatin, did well for about 5 months, and then had disease progression. So now the question is, what should be the second-line treatment option for this patient with metastatic TNBC? And that's where Sacituzumab Govitecan comes in. It's a TROP2-directed antibody-drug conjugate. So as the name suggests, antibody-drug conjugate, it has three components. The first is the antibody. The antibody is against TROP2. The second component is the linker. And the third component is the payload, the drug, which is SN38, the active metabolite of irinotecan. The way it works is that it's an antibody-drug conjugate. The antibody binds to the antigen, which is TROP2 in this case, which is overexpressed in cancer cells, including triple-negative breast cancer. And we can see this in the diagram. Sacituzumab govitecan binds to TROP2, then gets internalized. And then once it's inside the cancer cell, through lysosomal drug release, SN38 is released. SN38 is the active payload. That causes topo1 inhibition and DNA damage and results in apoptosis. So that's how the drug can release selectively high doses of toxic payload like SN38 to cancer cells. Now, these newer ADCs also have the so-called bystander effect. And what that means is that the SN38 can also be released in the tumor microenvironment. So even if there are cells that do not express TROP2, this agent would work because of the bystander effect. We know that tumors are complex, and you can have a tumor with some cells expressing TROP2 and other cells not expressing TROP2. But because of this bystander effect, it can address TROP2 heterogeneity and still exert its anti-cancer effect. So we reviewed the mechanism of action of sacituzumab govitecan and the excitement related to this drug. So I'll move on to the second module, which is about the data related to antibody-drug conjugates for treatment of triple-negative and hormone receptor-positive breast cancer. And for this, I'll hand it over to Dr. Hamilton.
Thanks so much. So happy to go through the current TROP2 targeting ADC that we have approved in this setting. So this really is to build upon the slide that Dr. Bardia walked us through, really about the design of this molecule. Again, it's an antibody-drug conjugate. The antibody is targeting TROP2, which, as you can see on the bottom left, is highly expressed in triple-negative breast cancers. Over 90% of triple negatives do express TROP2, so a widely expressed target that is actionable for our patients. The SN38 payload is 136-fold more potent than the parent compound, which is irinotecan or a topoisomerase 1 inhibitor. And this really allows unique delivery through the linker with a drug-to-antibody ratio of almost 8-to-1, about 7.6. To allow us to find these TROP2 positive cells and then deliver a chemotherapy payload directly to those cells, while hopefully sparing a lot of the rest of the body from some of the side effects. On the right side of this slide, you can see the initial data. This was triple-negative breast cancer in the third, fourth, even fifth line. This was a phase 2 study, and you can see the waterfall plot here really showing that the vast majority of patients received benefit and had some tumor shrinkage. The clinical benefit rate, which is defined as all patients that had a complete response, a partial response, or stable disease that lasted at least 6 months in duration, of about 45% here. Again, 74% of patients did have some decrease in the size of their target lesions. And, this was a pretty large study with really over 100 patients treated. So the duration of response ended up being 7.6 months, and the median progression-free survival here was 5.5 months. So this led to the phase 3 confirmatory trial. This trial was called ASCENT, and this was sacituzumab govitecan in pre-treated metastatic triple-negative breast cancer. Again, all patients here did have metastatic disease. They'd had at least 2 chemotherapies for advanced disease. There was no upper limit of how many chemotherapies patients might have received. One of these 2 could have been in the early setting if patients quickly relapsed within 12 months of completion of neoadjuvant or adjuvant therapy. And again, this was a global study as well. A little over 500 patients were randomized in a 1-to-1 fashion of sacituzumab on days 1 and 8 of every 3-week cycle, or treatment of physician's choice, which was a host of standard chemotherapies, including eribulin, vinorelbine, gemcitabine, and capecitabine. And patients continued either until their disease grew or they had another toxicity or reason from withdrawing from the study. So these are the results. On the left, you can see progression-free survival. Really, our standard chemotherapies only giving a progression-free survival of 1.7 months here, but Sacituzumab Govitecan coming in at 5.6 months, so a hazard ratio of 0.41 that was highly statistically significant. And if you go over to the right side of the slide, even more impressive was the benefit in overall survival. For patients that were treated with standard chemotherapy, it was 6.7 months, and those receiving Sacituzumab Govitecan was over a year at 12.1 months for an absolute magnitude of benefit of 5.4 months. So I think, clearly showing the profound activity of Sacituzumab Govitecan, but also a sobering reminder for us that even good standard chemotherapy that we use every day is really underperforming in these patients with aggressive triple-negative disease. So what about when we look at subgroup analyses? This is broken down by TROP2 high, medium, or low, and then again in this kind of red and yellow schema, TROP high, medium, and low for our standard chemotherapies. And you can see across the board, regardless which section you look at, that the patients that were receiving Sacituzumab, regardless of TROP2 expression, were overperforming compared to their counterparts that were on standard chemotherapy. So again, another reassuring tidbit, kind of telling us that we don't need to be testing for TROP2 or worrying about whether the patient is medium or high, that universally this drug is outperforming chemotherapy in our patients. And what about survival outcomes? You can see Sacituzumab Govitecan represented here in green, and our other standard chemotherapies that I won't read through in the various other colors. And there really was not one chemotherapy that was doing better than the others, but universally Sacituzumab was outperforming all 4 of the other chemotherapies. There were also 10 patients in the Sacituzumab Govitecan arm that had a complete response versus only 2 in the treatment of physician's choice arm, and this was actually the eribulin arm. And the median duration of response was 6.3 months for Sacituzumab and ranged from really around 2 months to less than 4 months for the treatment of physician's choice. So when we look at overall response rate, this came in at 35% for Sacituzumab Govitecan and only 3 to 6% for treatment of physician's choice. So again, kind of once we're in that third line and beyond space for chemotherapy for triple-negative disease, it's really not a fair expectation to be expecting a large response rate from standard chemotherapies. So clearly much better here with Sacituzumab.
So at ASCO 2022, we reviewed the final results from the ASCENT trial. As a brief reminder, ASCENT was a trial that looked at Sacituzumab Govitecan, a TROP2-directed antibody-drug conjugate, against standard chemotherapy for patients with pre-treated metastatic triple-negative breast cancer. The trial met its primary outcome. The median PFS and OS were both improved with Sacituzumab Govitecan, with more than doubling of PFS and OS with Sacituzumab Govitecan as compared to treatment of physician's choice, improvement in response rate, clinical benefit rate. All the endpoints were met with Sacituzumab Govitecan as compared to standard endocrine therapy. At ASCO 2022, we also presented the results related to quality of life, and there was improved quality of life with Sacituzumab Govitecan as compared to standard endocrine therapy. So the bottom line is that Sacituzumab Govitecan is a better agent both from efficacy and tolerability perspective as compared to standard chemotherapy like eribulin or vinorelbine, gemcitabine, capecitabine in pre-treated metastatic TNBC, and continues to remain the recommended standard of care in the second line and plus setting.
In April of 2021, the FDA granted regular approval for Sacituzumab Govitecan for patients with locally advanced or metastatic triple-negative breast cancer who had received at least 2 or more prior systemic therapies. At least one of them had to be in the metastatic setting. And based on this, we also saw a change to our NCCN guidelines, which can be an incredibly helpful document when you're in clinic and thinking about what may be next, with the addition of Sacituzumab Govitecan here in the red box under our preferred regimens for unresectable stage 4 disease.
Thank you so much, Dr. Hamilton, for reviewing the data and providing perspective as to why there's interest in this drug as second-line therapy for patients with metastatic TNBC. And that's exactly what was done for this patient. This patient received or started treatment with Sacituzumab Govitecan. So if you look at the current treatment roadmap for metastatic TNBC, the idea is a patient with metastatic TNBC at the time of diagnosis should be evaluated for PD-L1 status in the tumor. If the tumor is PD-L1 positive, then the treatment should include immunotherapy with a drug like pembrolizumab. The choice of chemotherapy backbone essentially is based on whether the patient had disease recurrence within 12 months from adjuvant therapy or more than 12 months. If it's within 12 months from adjuvant therapy such as ACT, then the chemotherapy backbone could be gemcitabine carboplatin, a drug that the patient has not received before. But on the other hand, if it's more than 12 months, particularly 2 or 3 years since the completion of adjuvant or neoadjuvant treatment, one could certainly use nab-paclitaxel or paclitaxel along with pembrolizumab. If a patient has germline BRCA mutation, one could also consider the use of a PARP inhibitor, either first line or second or third line setting. If a patient does not have a tumor that is PD-L1 positive, so PD-L1 negative, triple negative breast cancer, the choice would be chemotherapy for a patient who does not have germline BRCA. If germline BRCA is present, one could certainly consider a PARP inhibitor. So that's first line. In the second line setting, the preferred treatment is Sacituzumab Govitecan, as reviewed by Dr. Hamilton based on the ASCENT trial and emerging data. One should always consider clinical trials, including novel antibody-drug conjugates, trials looking at combination of immunotherapy with novel agents. Those should always be considered. So I would emphasize that in the first line setting, it's important to look at biomarkers. In the second line setting, consider Sacituzumab Govitecan, but always consider clinical trials at each decision point. And this requires a discussion with the patient, also requires a multidisciplinary team. So Maria, I'll be curious to hear your thoughts about the role of interprofessional collaboration, the role of nurses and other team members as we think about taking care of patients with breast cancer.
Thank you, Dr. Bardia and Dr. Hamilton, for laying the foundation for our discussion today. So Dr. Bardia and I are very fortunate to work together at MGH, and we are also very fortunate to work in a very collaborative environment where we're really able to pull on resources to take care of the patient, beyond treatment, but helping them, manage their lives at home, helping them manage their pain and symptoms with palliative care. And really, there's so much that goes into the patient's experience, more than just them coming in for their infusion every week. So here is just an example of what we ideally like to see happen for the patient, that the patient's at the center of all of our focuses, and between nursing, APPs, providers, pharmacy, social work, palliative care, rehab settings, that we're all doing our best to serve the patient, under with keeping them at the center of our focus. We want to come to them. We don't want them to have to shuffle around and come to us. And I think what really makes a huge difference here is strong communication. When you have a team that is strongly communicating on the patient's behalf, their outcomes are so much more optimal, and it really makes such a tremendous difference. Unfortunately, when we think about moving into the community, sometimes these resources are not as available, and truly this can impact the patient's experience. It can impact the provider's comfort level with utilizing, newer treatments like this when they haven't had experience, or, they haven't been able to keep up with the evidence or the, new treatments and how to manage the side effects. And if they don't have the experience, it's definitely a barrier for these patients, which really underserves them. So I'd like to ask Dr. Hamilton what her experience is, being that Dr. Bardia and I work together here in Boston. We'd like to hear from you on your perspective.
Yeah, thanks so much, Maria. I think you're right. I think, community oncologists, and particularly those that kind of see all tumor types, really kind of are the heroes here of trying to keep up with the literature across multiple subtypes of not only breast cancer, but all other types of cancer. So we really serve as a referral base. I have many people just kind of call my cell phone of, hey, I have, somebody, this is what I'm thinking of next. Do you have any other ideas? And we certainly welcome those calls. We're lucky to be, a large clinical trial referral center. I think one of the important points about clinical trials is that there was a survey actually done recently that many patients are not even aware of clinical trials, or that one would be available to them. So I think it's very important for providers to bring up the possibility for a clinical trial, even if they don't have them locally, but also just as a community, we need to start talking about clinical trials more often. So it's probably not the right time to hear about one if you've just been diagnosed with cancer. So really kind of make this more of a household acceptable thing to talk about, so people are aware of a clinical trial before they get diagnosed or a loved one gets diagnosed when everything else is coming as a shock to them.
That's such a good point. I think that there's, such a stigma and some fear even associated with clinical trials, and, normalizing it and showing it at a much earlier line in people's, patients' treatment histories is so important. That it needs to be more normalized for them. Thank you so much for that. So this next slide is basically reinforcing, really, and recognizing the disparities and the need to provide equitable care to all patients with breast cancer. There's some pretty, disheartening facts here, which unfortunately, just demonstrate why we just need to do better for these particular populations. But so Black women have lower rates of diagnosis of breast cancer than white women. They are typically diagnosed at a younger age, at later stages, and typically with more aggressive forms like triple-negative breast cancer. They represent about 21% of the population, and they also unfortunately have the highest death rate. So this really shows why access to these novel therapies is so important, and earlier treatment, earlier diagnosis, more awareness is so important, because these women are dying, and we can do better for them. So racial and ethnic minorities are also more likely to experience delays in therapy. They're less likely to obtain, adequate treatment, and they're also significantly underrepresented in clinical trials. And that's a huge problem, because I think when, patients are, asking about what types of, what patients like me have participated in this trial, and when you don't have a lot to pull from, it's hard. I think people feel comfort in numbers, and they feel comfort knowing that, their particular, background, history is being represented, and it's really important that we tap into all of these, different groups. So Dr. Bardia, I'd like to ask you, what did we learn about race in the ASCENT data?
That's a great segue. So we did look at race in the ASCENT trial as well, because as you brought up, it's a very important point to ensure that all the racial groups are deriving benefit from a drug and also have access to the drug. So in the phase 3 trials, about 10% of patients, 12% to be exact, self-reported their race as Black. And we looked at the outcomes in terms of both progression-free survival and overall survival in this group. And essentially, patients did derive benefit. There was improvement in progression-free survival. And in terms of overall survival, the overall survival with Sacituzumab Govitecan was more than a year. So it is important that patients get access to drug and they're able to derive benefit from these cutting-edge therapies. Now, the drug does have side effects. It does work, it's better than the current standard of care, but does have treatment-related side effects, and that's largely because of the SN38 payload. The three most common side effects with this agent includes myelosuppression, with neutropenia being quite common. The incidence of grade 3, which is ANC of less than 1,000, is 46%. So pretty much 1 out of 2 patients will have grade 3 neutropenia with the use of Sacituzumab Govitecan. The trial did not allow primary prophylaxis, but secondary prophylaxis with GCSF is definitely allowed and actually recommended. The second side effect is diarrhea. Because of the SN38 payload, the drug does cause diarrhea. The incidence is much lower than irinotecan, but it is a side effect that we tend to see, along with nausea and sometimes vomiting as well. So it is important that patients receive anti-nausea medications and also have a prescription of Imodium. So if they have diarrhea over the weekend or after hours, they have access to Imodium to control the diarrhea. The third side effect is alopecia. This is an agent that tends to cause alopecia, so it's important that this is discussed with patient. These are side effects that can be managed with supportive therapies. In the clinical trial, AEs leading to treatment discontinuation was low, less than 5%. So it's important to be aware of these side effects and manage them with supportive therapy. So coming back to this patient was started on Sacituzumab Govitecan. On cycle 2, day 1, was noted to have grade 3 neutropenia with an ANC of 800. The patient was afebrile. So the question is, what should be done next? How can we manage the neutropenia? There are guidelines for this. Sacituzumab Govitecan induced neutropenia is something that can be managed with holding the drug, allowing the ANC to improve, and once the ANC improves, then you can restart the medication. If needed, you can also use GCSF. If you are seeing that the neutropenia is recurrent, you can also consider dose reduction. You can dose reduce to 7.5 milligram per kilogram, so 25% dose reduction, and if needed, even 50% dose reduction of Sacituzumab Govitecan. And usually with dose reduction and holding the drug, for majority of patients, you can continue the patient on this medication. Treatment discontinuation because of neutropenia in the clinical trial and in clinical practice as well is pretty low. In terms of management of diarrhea, if a patient has diarrhea during infusion, it's likely because of a cholinergic reaction. It's not common, but something that has been described. So if a patient has diarrhea during infusion, the use of atropine is recommended because it's likely from a cholinergic reaction. But the common scenario is that the diarrhea occurs a day later, sometimes even days later after the infusion. And if that's the case, then we would recommend loperamide. You can start with 4 milligrams, and patient can take 2 milligrams after each loose stool up to 16 milligrams a day. Once the diarrhea improves, the patient then can start treatment with Sacituzumab Govitecan again. Now, if the diarrhea does not improve with high-dose loperamide, there are other medications you can consider, like octreotide. But I would say for majority of the patients, you can control the diarrhea with the use of loperamide. In terms of management of other AEs, hypersensitivity, if a patient has hypersensitivity to Sacituzumab Govitecan, as with any other infusion-related reactions, the recommendation is to stop the drug and then infuse it slowly over time. It depends on the grade as well. It's usually grade 1, grade 2, and with slower infusions, you can manage that. If a patient has grade 4 or high-grade hypersensitivity reaction, then the drug should be permanently discontinued. And then finally, for nausea, vomiting, it's recommended that patients should be pre-medicated with 2 or 3 drug regimen. I generally tend to prefer 3 drug regimen as long as the patient can tolerate that, so that they have a better experience to start with. And if a patient is really doing well with subsequent cycles, you can decrease from 3 drugs to 2 drugs. You have to warn the patient about potential side effects from the anti-nausea medications, such as constipation that can be seen with drugs like ondansetron. If a patient has severe nausea, grade 3 or grade 4, then you should hold the drug, allow the nausea to improve, and then you can restart the medication. Usually with this supportive medication use, you can control these side effects and patients can continue on Sacituzumab Govitecan. So we'll now move to the final module, which is how do things look in the future related to TROP2-directed antibody-drug conjugates, and would like to get Dr. Hamilton's perspective on future directions.
Thanks so much. So I'm going to cover a few slides about where Sacituzumab is going, and then I'll hand it back to you, Dr. Bhartia. So you can see here the ongoing phase 2 in metastatic disease, and then also SACI-IO for hormone receptor positive disease. So I think this is obviously a very exciting trial and really trying to expand where we currently have IO benefit for our breast cancer patients. And then on the bottom, again, a very exciting trial, SACIA. This is a phase 3 for patients that have had residual disease after neoadjuvant chemotherapy. And this is a trial for HER2 negative, so both triple negative and hormone receptor positive that we would traditionally describe.
So at ASCO 2022, we saw the first results from the TROPiCS-02 trial, a pivotal phase 3 trial looking at Sacituzumab Govitecan, a TROP2-directed antibody-drug conjugate in heavily pretreated patients with hormone receptor positive, HER2 negative metastatic breast cancer. This was in the third line plus chemo setting in hormone receptor positive breast cancer. Patients had received a median of 3 prior lines of chemotherapy. And in this setting, Sacituzumab versus standard chemotherapy showed an improvement in progression-free survival with a hazard ratio of 0.66. And if you look at landmark analyses, because there was initial drop in the curves and then separation, if you look at 12-month PFS rate, that was 21% with Sacituzumab Govitecan as compared to 7% with standard endocrine therapy. So improvement seen in progression-free survival with this agent in heavily pretreated ER-positive, HER2-negative breast cancer. In terms of overall survival, the results are not mature yet. There appears to be a trend, but I think we need additional follow-up before we can fully interpret the overall survival results.
Now, what about ongoing combinations? You can see here on the top that there are quite a few with checkpoint inhibitors, Sacituzumab Govitecan in combination with pembrolizumab. And if you read down on the right side, there's a first-line trial for patients that are PD-L1 negative. We're participating in this and are quite excited about it, as well as the hormone receptor positive trial we talked about, an early stage localized triple negative. So really kind of asking the question of, instead of giving naked chemo, as I call it, can we give antibody drug conjugate in combination with pembrolizumab? And then there's also a Morpheus triple negative trial in combination with atezolizumab. There are also combinations with PARP inhibitors. I participated in the C-STAR trial as well, and this was combining rucaparib with sacituzumab. And then there is another trial in combination with talazoparib, one of our other PARP inhibitors. So this obviously is very exciting, and we're trying to figure out where else we may be able to use sacituzumab, either alone or in combination. So let's go back to case 2 here, a patient from whom the clinical trial was being considered. Again, she was initially had a lumpectomy for a T2N0 triple negative breast cancer, received AC to T chemotherapy, and then several years later noticed shortness of breath, which prompted scans, and again, her triple negative breast cancer had returned. This is a patient that does not have BRCA alterations and is also PD-L1 negative. So I think that this is a great case. We traditionally think about potential for IO in these first-line patients. This patient is PD-L1 negative. And so really the current standard is single-agent chemotherapy. And I hope I've convinced you that single-agent chemotherapy is not the best for many patients. And so this is a patient that very well may be eligible for trial in combination with sacituzumab with immunotherapy in the first line, or other trials kind of looking at other agents earlier in their disease course. So Dr. Bhartia, I'm going to turn it back over to you to go through some of the other flavors of antibody drug conjugates that are in development.
Oh, no, thank you so much, and thanks for emphasizing why clinical trials are important, and at each decision point they should be considered, including the first line setting. In terms of other TROP2 directed antibody drug conjugates, there is another drug called Dato-Potamab deruxtecan, Dato-Potamab referring to the antibody and deruxtecan to the payload, and it's being evaluated for patients with metastatic triple negative breast cancer as well as other breast cancer subtypes. So it's differentiated from other drugs including Sacituzumab Govitecan in that while the antibody is against TROP2, the type of antibody is slightly different. The second is the linker. The drug has a tetrapeptide-based cleavable linker, which is different from Sacituzumab Govitecan. And then finally, the payload. It's a exatecan derivative deruxtecan, which is a topo-1 isomerase inhibitor. And the idea is that the antibody drug conjugate would get internalized in the cancer cell and release deruxtecan to the cancer cells. The drug also has a bystander effect. The drug can permeate in the tumor microenvironment and can impact cells that do not express TROP2. So this drug was initially evaluated in non-small cell lung cancer where efficacy was seen, and then was also evaluated in triple negative breast cancer in the TROPION pan-tumor 01 study. Patients with metastatic triple negative breast cancer who had received a couple of prior treatments and had measurable disease received Dato-Potamab deruxtecan at 6 milligram per kilogram. This drug is given every 3 weeks. The primary objective was safety, tolerability, and a number of secondary endpoints as well. In terms of what was seen with this drug, the drug did work. This is a waterfall plot, and you can see in patients with triple negative breast cancer, majority of patients had some tumor reduction. The response rate was 34%. Number of patients had stable disease as well, and in terms of the disease control rate, it was 77%. Now, the trial initially also allowed patients who had received prior Sacituzumab Govitecan or other TOP1 inhibitor-based antibody drug conjugates. And if we look at the responses in patients who had not received prior TOP1 inhibitor-based antibody drug conjugates, the response rate was much higher, was 52%, which would suggest that there is some cross-resistance between these ADCs. And if patient is receiving Dato-Potamab deruxtecan for the first time and has not received a TOP1 directed antibody drug conjugate, the response rate is going to be higher. And this has implications as we move into the future and think about ADC-based sequencing. In terms of side effects, the side effect profile with this agent was a bit different from Sacituzumab Govitecan. The drug caused mucositis or stomatitis. That's the number one side effect that was seen with Dato-Potamab deruxtecan. And surprisingly, the frequency of heme toxicity and the frequency of diarrhea was quite low. The drug does cause nausea, and it's important that patients receive anti-nausea medications before Dato-Potamab deruxtecan. In the triple negative breast cancer cohort, no cases of drug-related ILD were seen, but it is certainly a side effect that needs to be monitored. And similar to Sacituzumab Govitecan, for majority of patients with either drug hold or reduction or management of the AEs, you could continue the treatment. So treatment discontinuation due to AEs was very low, just 2% in this clinical trial. The key again is early recognition and management. In terms of ongoing studies with Dato-Potamab deruxtecan, it is enrolling patients with hormone receptor positive HER2 negative breast cancer. The TROPION Breast 01 trial is a randomized global phase 3 trial. Certainly an agent to consider if the trial is available at your institution. The second one is combination, combining Dato-Potamab deruxtecan with other agents, particularly immunotherapy, and that's the Begonia trial that's looking at Dato-DXd plus Durva. So in summary and key take-home messages, Sacituzumab Govitecan, a TROP2-directed antibody drug conjugate, should be the preferred treatment for pre-treated patients with metastatic TNBC in the second line and beyond setting. And there are ongoing studies looking at Sacituzumab Govitecan in combination with other targeted therapies, immunotherapy, PARP1 inhibitors, and also looking at Sacituzumab Govitecan in earlier lines as neoadjuvant and adjuvant treatment. There's another TROP2-directed ADC, Dato-DXd deruxtecan. It has shown activity in pre-treated patients with triple-negative breast cancer, and the drug is being evaluated not only for TNBC, but also hormone receptor positive breast cancer. And in terms of sequencing of these different ADCs, I think we'll need to understand mechanisms governing resistance. Is it because of the antibody portion? Is it because of the payload portion? And if we understand resistance, that could help us with therapeutic sequencing of these antibody drug conjugates for patients with breast cancer. We also need to look at the adverse events that are associated with these antibody drug conjugates. The key is early recognition and management. And usually with early recognition and management, including dose reductions if needed, we can keep patients on antibody drug conjugates so they can derive maximum benefit from these novel agents.
Dr. Bardia, I completely agree with your take home. I think from the opinion of the community, this is a relatively easy drug to give. We certainly have to be cognizant of the side effects of nausea, particularly diarrhea and the count disturbances. But again, nausea and count disturbances is something that we've all become quite familiar, and how to help our patients, and really going back to Maria's point that communication is key, setting the expectation that patients may have this, what to initially do if they do have it, and then what to call for if it's beyond what they're able to control at home, I think really makes this successful. I'm certainly very excited that we have this tool in our arsenal to use in the triple negative setting at this point.
Thank you, Dr. Hamilton. I totally agree. And I think coming from the nursing perspective, what I think about most often is how we can best support these patients. How can we educate them, as you said, on what to expect, provide them with the right medications to manage these side effects at home. And that includes their family members too. I think that ultimately, we've been in a tough position with COVID and not being able to have family members come in. And so now that we're starting to kind of see some, hopeful improvement in that, and we've been able to include more caregivers, it's been really important to help to translate some of these, supportive care guidelines that are familiar to us, but not familiar necessarily to them, especially if they're using this in earlier line, treatment, which is ultimately what we all hope for. We've seen such amazing, experiences for our patients at Mass General, at least, and we're just so grateful for this, opportunity for them, and to help patients live longer and to have less side effects and a, easier life.
When I met with Dr. Bardia originally to talk about treatment, I didn't know anything about a clinical trial. I didn't know what that entailed. Dr. Bardia brought it up and mentioned that to me, and I decided that I wanted to go that route because standard chemotherapy didn't work for me. My best advice that I can give anybody that is going through treatment or recent diagnosis of cancer is to be your own advocate. Nobody can advocate for you better than yourself. Know where you want to be, know what kind of life you want to live, know what you want to feel like at the end of the day. There are a lot of treatment options out there, but this clinical trial and these medications that I'm on under this trial have worked immensely for me. I can't say better things about Dr. Bardia and the team and the knowledge that he has and the questions he's been able to answer for me. He never leaves me second guessing the decisions that I make. And I can, they're very supportive, and the process of signing up for the clinical trial was very simple. There's a form that I had to sign, and then the process began.
So thank you so much for participating in the discussion today. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/JWM860. This activity is supported by an educational grant from Gilead Sciences Incorporated.